In this part of our cardiovascular pathophysiology lecture, we're going to address a couple of different pathologies. We're going to talk about hypertension, where we'll differentiate between left and right-sided heart failure, as well as differentiate between preserved and reduced ejection fraction left-sided heart failure. We'll compare and contrast the patho of endocarditis and pericarditis, compare and contrast peripheral venous versus arterial insufficiency, and then also take a look at some of the valvular dysfunctions and how they affect circulation as well as cardiac function. Let's start with talking about hypertension. One of the key things we want to remember about hypertension, whether it is primary or secondary, is that over time, hypertension, high blood pressure, increases workload on the heart. So the importance of that is it can have negative effects in someone who has atherosclerosis, as well as someone as lead to heart failure over time. When we look at the two major classifications of hypertension, we have primary or essential hypertension and secondary hypertension. We're going to talk mostly about primary, but we will also talk a bit about secondary hypertension. But the important thing to remember about primary hypertension is that it is not due to another pathophysiologic process. Many of these individuals with essential hypertension have underlying atherosclerosis as a major variable. If we're going to identify what we mean by hypertension, it's a sustained elevation greater than 140 over 90 in adults or greater than 150 over 90 if an individual is over the age of 60. If you're working with children, it's important to recall that hypertension norms are affected by age as well as size. And those of you that work in pediatrics, you're very good at knowing where to look those up and how to look those up. If you are in the family nurse practitioner program, those are some of the pieces you'll have to become comfortable with if you're not used to working with children. We also know that when we think about hypertension, some of the damaging effects, and what we want to remember is that with hypertension there is an increase in cardiac output, but there's also an increase in the peripheral resistance. So over time the heart muscle is likely to hypertrophy, and as a result a hypertrophied heart muscle, heart failure, hypertension is a very common etiology. We also have a good sense that there are significant negative systemic effects and damage of ongoing hypertension. And for the most part, this is hypertension that is not well controlled. But we also know that hypertension is called the silent killer because until it's very, very high, there are very few manifestations. It's estimated that in the United States, 70% of individuals over the age of 65 have hypertension, and this is essential hypertension. The damage that we see is primarily in small vessel disease, especially in kidneys, the retina, the brain, and of course the coronary arteries. Let's take a look then about the pathophysiologic risk factors. Is there a familial disposition to hypertension? Yeah, we can see it in families, but we don't have a single gene that has been identified. So there are probably some pieces of genetics that are very, very important, and we need to be aware of that. So a family history of hypertension would be important to pay attention to. With age, as we talked about, it's estimated that 70% of the individuals in the United States over the age of 65 have hypertension. Now, it's important to also look at whether this is diastolic or systolic. In our younger years, we are more likely to develop diastolic, an elevated diastolic pressure. However, as we get older, especially into our 70s, 80s, and 90s, the incidence of systolic hypertension becomes increasingly important. And this is because of the deposits of calcium in the media of the arteries that tends to occur as we get older, leading to stiff vessels and a loss of accommodation of our vessels themselves. So that's an important thing to remember when you think about elders. They are much more likely to develop severe systolic hypertension, and you may not see quite as much impact on diastolic hypertension. We know that catecholamines are important in the development of hypertension. When we first treated hypertension, we actually put them on Valium because we thought that this whole idea of the rapid and the release of catecholamines with high levels of stress, which we know catecholamines are vasoconstricting, so we figured if we can bring down their stress levels, make them calmer, we could treat their hypertension. Now, is that a possibility? Sure, but the vast majority of individuals with essential or primary hypertension do not have a catecholamine necessarily vasoconstricting etiology to their hypertension. A lot of the information that we have looked at has to do with some of the dietary pieces. And when I think about dietary, we are thinking about sodium, potassium, calcium, magnesium, but not only because of dietary means, but also the way our body manages those electrolytes. We do know, however, that individuals who are obese and also those who have metabolic syndrome have significantly greater levels of hypertension than the general population. But let's talk just a little bit more about electrolytes. So when we think about sodium and potassium, the first thing is that in hypertension, in general, sodium to potassium ratios tend to be higher. If you look at sodium intake by itself, it's important to think about whether or not an individual is sodium sensitive. Not all people with hypertension are sodium sensitive. So what that means is the amount of sodium in their diet may not be driving their high blood pressure. However, if they do eat a great deal of salt, that sodium impact may be in terms of volume, and their hypervolemia may be increasing their hypertension. So a great example of that is someone with uremia. Now, although that is something that we might want to say is certainly a secondary hypertension, and it is a secondary hypertension, that's the pure cause of their hypertension, you have to think about the relationship of sodium and volume and how that elevated volume could be facilitating hypertension. With potassium, in addition to that sodium to potassium ratio, in a lower potassium environment, potassium is actually somewhat vessel protective, and there are two ways in which potassium levels can be protective. One is that it facilitates that normal sodium potassium ATPase pump and helps us keep those vessels in good health. But the other thing is potassium is in physiologic levels has the ability to keep that endothelium level healthy, as well as facilitates relaxation of the media. With calcium and magnesium, we talked about briefly the role of calcium deposits themselves in the media, leading to stiff vessels. And then we also look at magnesium and the calcium and magnesium relationship. Magnesium has increasingly been recognized as having both direct as well as indirects on blood pressure. The direct effect of magnesium is the ability to relax vascular smooth muscle cells. So if you relax those vascular smooth muscle cells, the blood pressure would be lower. The indirect effect of magnesium is in the regulation of potassium and calcium ions. When magnesium is low, potassium also tends to be low. Remember that protective effect of potassium. At the same time, intracellular calcium tends to be elevated. And as a result, then that calcium pump, which can lead to vasoconstriction, would be problematic. Finally, magnesium helps drive that sodium-potassium ATPase pump that is so important in maintaining electroneutrality and in the movement of sodium and potassium across cell walls. And now we're back into thinking about the relationships of potassium, calcium, magnesium on action potentials and movement of electrons. Two of the major mechanisms as we think about hypertension, essential hypertension, are the renin-angiotensin-aldosterone system and sympathetic nervous system activity. So we know that with the renin-angiotensin-aldosterone system, we're looking at two essential areas. We're looking at both volume as well as vascular resistance. When renin comes from the juxtaglomerular apparatus, and under the influence of renin and aldosterone, you will facilitate the retention of both sodium and therefore water, as well as increase that resistance. Remember that angiotensin 1, which is part of your renin-angiotensin-aldosterone system, converts to angiotensin 2. Angiotensin 2 not only is a powerful vasoconstrictor, it also has the ability to facilitate vascular change. And so you'll see with very high levels of angiotensin 2, endothelial dysfunction and vascular remodeling. We also recall, I know you remember this, that we have to balance the renin-angiotensin-aldosterone system with natriuretic peptide, because natriuretic peptide is released in stimulus in relationship to stretch. And when you have stretch, then the BNP will counterbalance the effect of the aldosterone. In sympathetic nervous system world, there is an increased production of catecholamines. In addition to that, there is an increased receptor reactivity to those catecholamines. So not only are you producing more, those receptors are more reactive. When you have that catecholamine effect in high blood pressure, this then leads to vascular remodeling and changes within those vascular walls. In addition to that, the overproduction and the increased receptors to those catecholamines can facilitate insulin resistance and therefore metabolic syndrome. One of the critical things we see in metabolic syndrome is insulin resistance and hypertension. With that catecholamine release, you also will see an increased renin-angiotensin mechanism as well. So if you think about what we do in terms of treating hypertension, you can see how we are essentially attacking both the volume as well as the vascular resistance pathways or mechanisms. When we give diuretics, we're working on the volume. When we give angiotensin inhibition, we're trying to decrease the conversion or block angiotensin 1 to angiotensin 2 or block the receptors. With calcium channel blockade, we are trying to decrease the influx of calcium into the cells, which then would cause vasodilation. Because remember, when the calcium runs into the cell, you're going to have constriction. And with beta blockade, we're decreasing the beta adrenergic effect on the vessels, therefore decreasing the heart rate, the contractivity, and the release of renin by those juxtaglomerular cells. Secondary hypertension, as opposed to essential hypertension, where we don't really know exactly what's causing it all the time, is due to another key pathology. And there are 4 key pathologies that I would encourage you to have a recognition of. Not so much a deep understanding, but recognize that these 4 are for the more common pathologies. The first is renal artery stenosis. Now, in order for a renal artery stenosis to cause a secondary hypertension, it is usually a bilateral renal artery stenosis, or it's a unilateral stenosis in a single functioning kidney. So what happens in that stenosis is the stimulation of the renin-angiotensin-aldosterone system. In pheochromocytoma, this is all about catecholamine release. And a pheochromocytoma is a tumor of the adrenal medulla. It's a mass of the adrenal medulla. Generally, pheochromocytoma is identified during a time of stress. Makes sense, because during a time of stress, you have a huge outpouring of catecholamines from the adrenal medulla. One of the most common times when this is uncovered is in pre-op, and certainly if you were going to take me to surgery, I'd be pretty stressed. Kidney disease, we've talked about sodium and water retention because the kidneys aren't able to work, and then this idea of pregnancy-induced hypertension. Women who develop pregnancy-induced hypertension are more likely to develop hypertension later in life. Therefore, it's considered a risk factor for hypertension later. Your textbook has a great table. It's table 32-3. And when you look at that, I think the impact of the table is that there are a fairly large number of pathologies that can lead to hypertension. The other piece that I wanted to mention about hypertension was in a study. There were 2 very small studies published early in 2016, and they were out of Canada, but they looked at very preterm infants, and these infants were less than 29 weeks gestation. And they followed these infants over a very long period of time, and they identified that these adults who started their life at less than 29 weeks gestation had an increased risk of hypertension in young adulthood, and this was in their 40s. They theorized that this may have been tied to smaller than normal kidneys at birth, and as a result, they had impaired function of endothelial cells lining that led then to some changes in endothelial lining in the intima of their cells. So that again, those were 2 somewhat smaller studies, but I wanted to mention them because when you work with young adults, or when you work with children, just having a sense that there is a greater risk if that child was born prematurely, because of the potential for an increased risk of hypertension later. Let's turn our attention then to heart failure. Heart failure, we're going to separate them into left and right. And on the left heart failure, we'll separate those into reduced ejection fraction and preserved ejection fraction. One of the major risk factors of heart failure is hypertension. When you look at hemodynamics of hypertension, heart failure, and reduced ejection fraction used to be called systolic, but we're not calling it that anymore. We're calling it reduced ejection fraction. So the changes in hemodynamics in reduced ejection fraction include decreased contractility, which could be from an MI, from ischemia, or from a cardiomyopathy. And this cardiomyopathy could be from an infection, could be idiopathic, could be postpartum. It could be from an increase in preload. Now remember, ejection fraction is the amount of blood ejected from the ventricle each beat. So preload is the pressure at the end of diastole. So it's the left ventricular end diastolic pressure. So if we increase that preload, the kinds of, you would have a higher left ventricular end diastolic volume as well as pressure. The pressure comes from the volume. But there's also, the other hemodynamic is increased afterload, and this is where hypertension comes in due to increased peripheral resistance. So you have that increased resistance decreases the cardiac output because it's pumping against so much resistance to ejection at the end of systole. The greater the afterload, the lower the cardiac output. Remember Starling's law? Starling's law is going to help us as we think about stretch. The volume at the end of diastole is directly related to the force of the contraction. So if you have greater stress, you have greater force of contraction and the amount of blood that should be ejected. However, we know that stretch and contraction have limits, and pathology occurs when we exceed those limits to stretch and keep that force of contraction up. So we've talked about hemodynamics. Let's think about the neurohormonal factors in reduced ejection fraction heart failure. Once again, catecholamines, increasing that heart rate. So if you increase that heart rate, you can see how you're not able to keep up that force of contraction or do as good a job of ejecting enough blood from that ventricle. Renin-angiotensin-aldosterone. Renin-angiotensin-aldosterone, that aldosterone and that ongoing, the changes because of this ongoing mechanism in heart failure actually changes the architecture of the cells and causes remodeling of the ventricles. This is why we use aldosterone antagonists. We're not using aldosterone antagonists like aldactone so much because we want their diuretic effect. We're using it because it will antagonize the aldosterone, and the aldosterone is driving the change in the architecture and the remodeling of the ventricles. We've talked again about natriuretic peptides. Remember, we talked about the role of B-type or brain-type natriuretic peptide in both diagnosing and evaluating therapy outcomes, because the whole idea is to determine whether or not there is stretch. Again, it's most useful in looking at it trending and looking at it over time as opposed to a single value of that. In heart failure, in reduced ejection heart failure, inflammatory cytokines have been initiated and stimulated. And this would include endothelin from the inner lining of the heart itself, the muscle itself, tumor necrosis factor, and interleukin-6, because you have injury to that endothelial surface because of the stretch and the stress on the heart. And then last but not least, again, metabolic dysfunction, which leads to insulin resistance, which also is part of the pathology or can be a component of the pathology of a reduced ejection fraction heart failure. Now, just so that we're all still on the same page, I probably should have started off with this, but remember what an ejection fraction is. We talked about that's the amount of blood ejected from the ventricle each beat. A normal ejection fraction is right around 50%, maybe 55%, because you can't ever completely empty that left ventricle. So when you have a dilated heart because of this heart failure, The myocardial fibers have to increase a lot of tension in order to produce enough pressure in the ventricle to empty that pressure. So as the pressure begins to decrease, the fibers begin to shorten, and that decreases the ability of the heart to eject what's in the chamber. Now, we also know that preserved ejection fraction is important. So this is an individual, and this is a fair amount of individuals who have heart failure, and one of the most common etiologies or pathologies that leads to a preserved ejection fraction heart failure is hypertension. Preserved ejection fraction heart failure used to be called diastolic. But again, we're not using that anymore. Now we're calling it preserved. Because what happens here is if it's isolated or it may be in combination with systolic, you have decreased compliance and abnormal diastolic relaxation. However, the heart, that ventricle, is still able to push enough of that blood out of the ventricle. That's why it's preserved ejection fraction. Now, the other common etiology could be ischemia-related myocardial remodeling of that ventricle. So as a sequela of a myocardial infarction, especially if I think it's an inferior MI, you may see symptoms of preserved ejection fraction heart failure. So when you look at their ejection fraction may still be 50%, but when you look at their chest x-ray, they have a very large heart. Over time, that left ventricle continues to lose more and more compliance. That pressure increases, and as the pressure on the left ventricle increases, you also see left atrial pressure increasing. When that left atrial pressure increases, that can then lead to pulmonary edema because the blood is going to go to the path of least resistance. So one of the ways you have of looking at a manifestation of the difference between reduced ejection fraction and preserved ejection fraction is through your heart sounds. In a preserved ejection fraction heart failure, you're more likely to see or hear an S4 gallop, because what's happening is when the heart contracts, there's a little bit more blood being pushed into the ventricle. With an S3 gallop, this is an overdistension sound and is more likely to be heard in a reduced ejection fraction heart failure. You'll also hear an S3 gallop in someone who is volume overloaded. If you relieve that volume overload, the S3 gallop goes away. So an S3 is a systolic heart sound, and S4 is a diastolic heart sound. And you'll learn that in your assessment, but I thought you might find that helpful as you think about the dynamics of this disorder. Now, heart failure doesn't only occur on the left side of the heart. So we think so much about the left side of the heart that we forget the right side of the heart. But when you see right-sided heart failure, it's the failure of the right ventricle to provide circulation to the pulmonary circulation. Frequently, right-sided heart failure is a result of left-sided heart failure and increased resistance for the right ventricle, an increased resistance that right ventricle has to overcome. So if you think about all this blood on the left side of the heart, it's backing up to least resistance. Well, we're in the pulmonary system, so where's it going to back up to next? Right ventricle. Exactly, because that's the pump on your right side of the heart. So as a result then, the way you find a right-sided heart failure and the manifestations of that is that the blood backs up into the venous circulation. because remember the right ventricle is your venous return side. Left side is your arterial supply side. So you look for the manifestation of that in jugular vein distension. You look for abdominal as well as dependent edema, and you look for splenomegaly and hepatomegaly from vascular congestion. This vascular congestion within the liver and the spleen. Not only can you palpate the liver, but one of the ways this often manifests is a patient will tell you that they eat a little bit and then they have this horrible feeling of fullness. They just can't eat anymore because they feel full all the time. Well, that's because they have so much congestion there that they have early satiety. And this is one of the things we always ask about in a heart failure clinic. This feeling of early satiety and fluid collecting in the abdomen, and this because of this congestion often occurs before peripheral or lower extremity edema is terribly obvious. And of course, jugular venous distension, great way to look at it, and something you'll learn in your assessment course because it's so important. Now, if your patient has right-sided heart failure and does not have left-sided heart failure, they should be evaluated for pulmonary hypertension because that right ventricle is pushing against a lot of resistance in the pulmonary vascular system. So let's, instead of talking about the heart muscle itself, let's talk a little bit about the linings of the heart. And that would be, so we're going to talk about pericarditis and endocarditis. So with pericarditis, and it's important, and I expect that you'll be able to differentiate between a pericarditis and an endocarditis. So with a pericarditis, you are looking at outside the muscular sac. We know that the heart is contained in a sac. There's a small space, and then there's the pericardium outside that. And so this may be idiopathic, which means we're not completely sure what caused it, viral, or it may be due to connective tissue disease. The common connective tissue disease would include sarcoidosis, or this could actually be uremic. Now, that's not a connective tissue disease, but a uremic pericarditis can occur because of the irritation of the uremic, the nitrogen-based uremic toxins. But generally, we think about a pericarditis as being inflammatory or infective. So when we look at a pericarditis, you would look for signs of inflammation or infection: fever, malaise, chest pain, and friction rub. Now, unfortunately, less than 50% of individuals with pericarditis will actually develop a friction rub. But if you hear it, you're pretty sure that you know that they do have a pericarditis. So we have collection of fluid in the pericardial sac. And I'm going to flip to a picture here. So here's your pericardium, and of course your lovely heart. So what happens with this pericardial effusion is you get more and more buildup of this fluid within that sac. So it's building up within that sac there, which should be fairly close to the heart. As a result then, that fluid buildup, because it's not going to go out here, it's going to press inside to the heart itself. So it decreases the ability of the heart to both contract as well as fill. So what would that do then to the ejection fraction? Decrease it, yes. So you have a decrease in that ejection fraction. Let's go back to the previous slide and talk about endocarditis. Endocarditis is in the inner lining itself, so that inner lining of the heart as opposed to the sac. This is virtually always, this is not virtually always, but it is almost always infective, especially staph and strep. So you know then that an endocarditis is usually from an exogenous source as opposed to an endogenous source. The biggest thing we worry about with endocarditis is that this will affect the heart valves. And endocarditis, because it's due to staph or strep, look for this in folks that have had an indwelling central line, maybe IV drug users, and following dental procedures. Because during a dental procedures, I just had my teeth cleaned this morning, and you know, when they're working on my teeth, there's always a little bit of blood there. So you know that someone who has very poor dentition and they had a very aggressive dental procedure or a tooth pulled, that those organisms that we're exposed to gain entry and could actually begin growing on our valves. So the essential elements of an endocarditis, which remember, inner lining, you have endocardial damage, because the endothelial basement membrane has been exposed. The microorganisms then adhere to that endocardial surface and damage them. The adherent bacteria then form vegetative lesions on the valve surfaces themselves and begin to destroy those valves. Now, at the same time, because you've had damage to the endocardial surface, the clotting cascade with the formation of fibrin has also been activated. These vegetations that form on the valves, along with these clots, can actually embolize. And that's why one of the things you look for in an endocarditis can be petechiae. These are very small clots, and petechiae are a manifestation of clotting in very small vessels. Valvular dysfunction. With valvular dysfunction, one of the most important things are the key concepts. So I want you to think about location, think about flow restriction or resistance, and the effect on exit chamber. So those three things, as you think about these valves that we're going to talk about and the processes we're going to talk about, you might want to build yourself a little table that actually puts that in perspective. Now, valvular dysfunction can be either congenital or it may be acquired. The acquired ones, we talked about an endocarditis, that those vegetative lesions would be an acquired from an infection, or could be acquired because of damage during an MI. Congenital means that the child was born with it. And in the section that we talked a little bit about disorders in children, we talked about some of the congenital vascular defects. Although those tend to be septal defects, they can also be born with valvular defects, although they aren't terribly common. All right, so what we're going to do is we're going to look at three major types of dysfunction. We're going to look at stenosis, regurgitation, and then we're also going to look at prolapse. And the specific valves, because they are the most commonly affected valves, are the aortic and the mitral valves. So let's think first about stenosis and the stenotic process. With a stenotic valve, whether it's from infection or due to injury, the opening between the valves have become narrowed. So you think about an obstructive process. As a result, then, this obstructive process increases the workload, and because it has to overcome that resistance. So in an aortic stenosis, remember the aortic valve is between the left ventricle and the aorta. An aortic valve stenosis would lead to left ventricular enlargement and decreased circulation to the periphery. This is the most common valvular dysfunction in individuals over the age of 65. And it is one of the more common congenital valvular defects. In an individual over the age of 65, the pathology may be due to vegetation, or it may be due to calcification, calcium deposits that are put down on the valve itself. So aortic stenosis causes left ventricular enlargement, decreased circulation to the periphery, more common in olders, but can also be one of the more common congenital defects. With a mitral valve stenosis, remember the mitral valve is between the left atrium and the left ventricle, you will see left atrial enlargement. Therefore, effects would be on the pulmonary system. So with this mitral valve stenosis, that left atrium is enlarging. Because of that enlargement, there is less blood going to the left ventricle, which could then manifest as a decrease in the cardiac output. With regurgitation, you're talking about a leaking valve. So think about recirculation and an incompetent valve because the flow is continuing through an incomplete closure. So once again, let's look at aortic and let's look at mitral. In the aortic, with this regurgitation, what you have is some of the blood from the left ventricle going back into the left atrium. So basically the left ventricle has to do the job itself. The job again. As a result then, there is going to be left ventricular enlargement because you have either increased the volume or you have put more blood back, so it has to do the work again. With a mitral valve regurgitation, you have left atrium enlargement because you have squirted more blood back into that left left atrium. So with a regurgitant valve, the blood is leaking back into the previous chamber and increasing the workload on that previous chamber because of an increase in that volume. When you have increase in the volume, then the chamber will dilate and it will also hypertrophy. So a regurgitant valve could lead to heart failure. Mitral prolapse is one of the most common overall leaflets that can undergo degeneration and thickening. With a mitral prolapse, you'll see this more commonly in young women and the leaflets move up into the left atrium during systole. And it actually leads to a mitral regurgitation. The most common manifestation of mitral prolapse is lightheadedness. They may have a sharp but intermittent chest pain at rest. It does not have an anginal character. And they may complain of palpitations and that lightheadedness, and it has to do with a decrease in the cardiac output. There's a suggestion that mitral prolapse may be genetic, and you will also see mitral prolapse in a genetic alteration called Marfan syndrome. Overall, when you have someone with valvular dysfunction, keep your eyes open for heart failure and the symptoms of heart failure. Table 32-9 in your text is a great table. So let's look at just a couple of pictures. There's your stenotic valve. You can see how they aren't able to open completely, but also they're unable to close completely. And they're very, very rich. And this would be, this could be from either vegetate. This looks more like a calcification to me. Hold on a sec. Trying to redirect me. All right, this is a regurgitant valve. With a regurgitant valve, you can see how this leaky valve is letting more blood back into the atrium. The last thing we'll talk about in this section are the arterial and venous peripheral alterations. When we look at arterial insufficiency, we most commonly just call this peripheral artery disease, or PAD. The majority of individuals with peripheral artery disease have the underlying pathology of atherosclerosis. And the atherosclerosis doesn't just occur in the coronary arteries or the cerebral vessels, it occurs in our periphery. Because of this atherosclerotic process this causes lower extremity ischemia, and this manifests as intermittent claudication. Intermittent claudication is pain with activity that is relieved by rest. As this atherosclerotic process continues, if there is an ulceration on the lower leg, it doesn't heal very well. Well, that makes sense because the arterial supply, which is taking the nutrients and the oxygen to the area, isn't getting down where it needs to be. So in addition to a poor healing ulceration or a necrotic area, they have a cool extremity, they have decreased pulses, and they have decreased hair growth. Now, an additional manifestation of arterial insufficiency is something called Raynaud phenomenon or Raynaud disease. Raynaud phenomenon is actually a vasospasm of the small arteries, arterioles in the digits. And basically what happens with this is an imbalance between vasodilation and vasoconstriction. This is more common in autoimmune disorders. So we'll see this in rheumatic disorders. You may see this in sarcoid disorders. You may also see this in lupus. But what happens in a Raynaud phenomenon is you have vasospasm. And as a result of that vasospasm, you have an influx of calcium into the cells. Remember, that rapid influx of calcium into the cells causes vasoconstriction. Classically, what happens in this, and it frequently is usually noticed first in the hands, just because we notice it, the hand becomes very cold and the tips of the fingers are actually white or blue, and it can be painful. And they have to actually warm the hand up, and it can take a while to warm that hand. But you see that white or blue tips on the hand. It's a vasospastic disorder. Venous insufficiency is obviously in the venous side. So this may be this is a chronic inadequate venous return. Now there are two common etiologies of this. One is a structural etiology, which would be incompetence of the valves in the veins. This is what happens with varicose veins. But the other could be due to long-standing peripheral edema. So that long-standing peripheral edema is something you might see in someone who has a reduced ejection heart failure, or who has long-standing pressure on that venous system. So because of the inadequate venous return, there would be stasis within usually it's the lower extremities. And this alters oxygen delivery to the cells. And with that hypoxia, you have an inflammatory process. This inflammatory process leads to fibrosis and sclerosis of the cells of the lower legs. Those skin cells and the muscle and the muscles of the skin and the subcutaneous area can lead to a very poor healing ulceration. And these ulcerations look different from the arterial ulcerations. Arterial ulcerations tend to be smaller. Venous ulcerations tend to be much, much larger, and they are surrounded by this edema. This edema causes the skin to be very leathery, and we call this brawny edema. And these skin changes are due to the stasis and the inflammatory process that actually changes the architecture as a result of this long-standing edema. So we've talked about a lot of things in this section and feels like we might have been all over the map. But some very common things sort of ran through this. The impact of atherosclerosis, the impact of calcium, and how calcium can be problematic. But think about the vessels, think about the valves, think about those structures and how arteriosclerosis, the inflammatory process initiating clotting cascades, where are the roles that they play within this? So in all of these things, it's important to identify what is this, how or why does it occur? Can you describe the pathology? And then what does that pathology look like? How does it manifest? I hope this has been helpful. Thank you for your attention, and please let me know if you have questions.